So recently at our program, we found somebody had, after a visit, taken all of their wrappers out on the parking lot and just scissored through them all, and we just found that, like, the little pieces on the end of the wrappers that would so it just looked like somebody was diverting from our program. So we kind of like flexed, and we basically brought the whole program in for an unexpected random count. And we unfortunately, there was so many anomalies in that experience that we couldn't ever determine who the person was who had done the misdeed with leaving a bunch of wrapper pieces there together on the lot. But we're going to be presenting one of the patients today who had anomalies that would be put under suspicion. But like I said, we have about 3 or 4 patients, and so I'm going to bring up several variations on this case to try to get a better idea of how we can handle suspected but not confirmed diversion without, I don't want to just be tossing people out, but at the same time, I don't want to look like I'm too light-handed with it if I'm getting DEA audited later. So these are high-risk cases in my view, and that's why I present them. So this first case, is in a 27-year-old lady who's been with us since 2017. Came to protect her custody rights and get off drugs, and basically has never done a thing wrong in our program in 2 years, been perfectly compliant with every rule, never had an abnormal drug screen of any kind. But on the 17th of September, she was just here for a routine visit, and a routine buprenorphine confirmation test was ordered, and it came back the buprenorphine level is said negative on the lab, but the actual quant was just less than 10, so it wasn't truly 0. There was some buprenorphine, but because it was less than 10, and historically she had never even been less than 100, but mainly because LabCorp uses a cutoff of 10 for whether it's negative or positive, it left this sort of gray area about whether she had any bupe in her system. Her norbupe was 75, and the prior screen on August 20th was bupe was 50 and norbupe was 362. So I guess I was incorrect when I was saying she'd never been less than 100, but historically it had been much better. I can bring them up here on my computer and give you a little more data on that before we move on. Let's see if I can do this with it. Actually, I don't think it's going to project on the screen, but it basically, I take back what I said. It's ranged 50 to 100 for a very long time on the bupe level, so they never really that high. And her dose is 12 milligrams, I think, right? So
right.
Yeah. So she is Hep C positive. We are still in the process of getting our patients with Hep C treated. We have not had much luck, even though we've referred many. But the Medicaid just changed the rules. We're going to be probably re-referring on that. Prior to coming to our program, she had a very long history of polysubstance use, but it's been a very long time. She's generally, pretty happy and but unmotivated at her group visits. She doesn't have a lot of support socially or family, and she really doesn't seem to be all that pumped up about recovery at this point. And she's a year or 2 years in, and she doesn't have much that she ever complains about. And she always reports no cravings, no withdrawal issues, just that the medicine works fine. And is sometimes a little stressed about her kid that she has to watch on her own. She, as I said before, she's been with us since 2017, and has, you can see in the BH history, she's always been good. But when she first came, she had been using street Suboxone already. And a history of childhood behavior issues with emotional disturbances going back as soon as 12, and a history of using benzos. But again, we've never had any issues with any intoxicating substances in the program. Going back to the questions that I was going to pose, I called her in after this abnormal buprenorphine level that was negative / less than 10 bup and very low norbup. And I said, can you explain to me why this might be happening? And she said that she had consistently been taking her medication. There's been no change in the way she takes it. And that she had had a recent kidney infection, though. And she showed me a bottle of antibiotics that she had been given. I can't remember the exact brand of it. Bactrim. Okay. And she said that she had been drinking very large amounts of water because that's how they told her to get rid of the kidney stone. But prior to me calling her in, there was no mention of all this UTI, kidney stone stuff in the main group sessions. So it was kind of, but she did have documentation in the form of that antibiotic bottle of what's going on. So I may have urine electrolytes. I'm looking for, yeah. I'm looking for the urine creatinine because I know you will ask. And it seems to be unavailable for this. I don't know why. But yeah, I do not have a urine creatinine on this date that she had the low bup. So what we did, I'll just tell you because now it's been a month before we could get this presented, and then I'll get feedback on what I should have done. What we did was we just accepted her explanation of what's up. And basically, she already had medications from the prior visit for the whole month. And we haven't had to give her any more medications since then. But I said I would just talk to WVU and probably plan to call her in for randoms, which I did call her in for one more unexpected random on October the 4th. And the buprenorphine levels from that visit were 15 and 128. And prior to that, two more unexpected randoms. There was also a September 25th random, which the buprenorphine levels, you may want to write this down, 624 and over 2,000. So in sequence, we have buprenorphine of less than 10 on the 17th, 624 on the 25th, and then on October the 4th, 15. Reporting consistent usage of the medication. So we will be seeing her back soon, and we're not sure how to apply the WVU code's policies and procedures for this kind of a situation, or if there is anything that needs to be done at all. So that's all I have.
Awesome, thank you. I'm going to ask first that anybody out there, any of the participants, do you guys have any questions or insights, thoughts?
When you called her in for a random, did you do a random pill count also? Or
count the wrappers?
Yeah, no, the wrappers, but not the actual medicine that she has left?
Well, if we do count the wrappers, okay.
We count the medicine they have left as opposed to the medicine that's open.
Okay.
Shut up with the dispense date.
Yes, Lois is informing me that yes, we did, and there were no issues with that. That those were always counted out right. Even when we called her in, and the way I called her in unexpectedly, after I had that at first abnormal bup confirmation, she couldn't have predicted it, and she still had the right wrapper count. But notably, that's when her levels were so high, I think. That's when they jumped up. That was the 25th, I believe. So, double check. Yes. Yeah, so I had the abnormal one from the 17th. It doesn't come back until like the 23rd or 24th, and so I called her in immediately, and she wouldn't see it coming. She had very high levels of bup, and then and checked again. Another couple weeks later, it's back low again.
Right.
Did you get her tested at the same time each day?
Like time of day.
Yeah.
It would be generally around 11 o'clock. Yeah, around noon.
Each time.
Within a couple hours of that. Yeah.
Does she take it all at once, or does she divide up the dosing?
Looking at my note here because I can't remember offhand. All right. We have a consensus on that she divides her dose, and I don't recall personally talking about it.
Okay.
All right, guys. You guys go for it now.
Dr. Tacker, what are your thoughts as our resident chemist?
Well, it almost seems like there was a dose missed September 17th. The ratio of Norbup to Bup is running about 7-to-1 to 10-to-1 in each of these scenarios, but hitting a less than 10 on buprenorphine is not as worrisome to me because she actually has Norbup present. If she was trying to simulate compliance, we would see very high Bup, but really very trace or negative Norbup, and that would be the questionable part. Since there's no naloxone in this check, it's kind of hard to cross-check it against the naloxone component. But it also seems like when you called her in, she took the full dose instead of the divided dose, because here you have a greater than 2,000 and a 624. So it looks like a load up. And then I don't know if it was a missed or a timing issue, but it came in just above cutoff that next time, as you point out. So it seems like she coasts a little bit. That would be what I see in the numbers. But
Yeah, I mean, Dr. Zhang may have a different idea, but it sounds to me that like you've done everything that I would have done, if not more, as far as safeguarding. And you called her in a couple of times for some pill counts. I would be more concerned if there was no Norbup present and just the buprenorphine present. That would make me more concerned for diversion. If there are no other red flags, then kind of the ones you've mentioned already, I would probably continue to do exactly what you've been doing.
Yeah, it's possible patients sometimes only take, partial dose. That's very possible. And also on DDU, when I ask them, a lot of times patients, if they don't feel well, they may take a higher, most of the medications in the morning. Sometimes they take, rest, or sometimes they take the whole film. Patient can change their schedule. We're talking about this addiction problem. They do not do it like very consistently. So seriously, that's what I ask a lot of patients. Another thing is like Dr. Berry said, like, as long as there's no Bup over there, and we do have some patients with low level as well.
Buprenorphine level.
Yes, no low buprenorphine level. So that's true. So yeah, I would do exactly the same thing. I don't think it's something we should change the treatment plan.
Yeah, and from what you've described, there's no indication that she's diverting. She's coming in with the strips, appropriate numbers, and everything else. And Dr. Tacker, how much do we really know regarding, correlation between dosing with buprenorphine and timing and levels, physiology, and all that stuff? I mean, is this an exact science right now?
no, it's really, there's a lot of encouragement to just give neg and pause. And that really makes people worry a lot because there's a dependence on numbers. But I was glad for the examples because then I could kind of look at her patterns, her metabolic patterns, because within this patient, we're seeing ratios that kind of hold up. And that's really more what I'm looking for is how is her liver responding to this, especially given that she has Hep C. I was kind of worried that she would be having some trouble activating and then it would really skew her numbers or make it look incriminating. And it doesn't seem to be so. So the fact that despite being on an antibiotic, and when you said Bactrim, the first thing I thought of was activation. Is this antibiotic hitting the liver, and the liver is actually activating enzymes so that she might metabolize differently for a little bit and then switch back to the previous pattern? It seems pretty consistent here. So that's kind of what I look for. Is I can't say because we saw 360, 250, that means she took a full dose 12 hours ago. We can't back calculate that way. We don't know her volume, her clearance rates. There's just too many factors that we don't know in that picture. But like I said, to me, those ratios matter a lot, and they are holding water. So.
Just because this is good for other folks to know, if it was all bupe and no norbupe, what would your concern be that they've dipped it?
Yes.
In many compliance.
Yeah.
Okay.
Yeah. So if you see, so for those who may have not been on the call before, or just may not know, so the buprenorphine medication should break down into its metabolite, norbuprenorphine, and the ratio, or you should have a greater amount of the norbuprenorphine than you have the buprenorphine whenever it's being tested. So if all you see is buprenorphine and no to very little norbuprenorphine, then that means that most likely they put a strip or a tablet in their urine and let it dissolve. And that's what's being read.
And it will look absolutely positive and clear on the cup, because the cup is calibrated with buprenorphine, and that's what it's looking for.
Yeah, so the
And
point,
it
so,
cross reacts a little bit, but if you get a positive cup result, you're like, oh look, it's positive, good job, and you may not know the profile that's there.
right, so if we were just looking at the point of care testing on the cup that we all give, if they had just put the strip or the tablet of Suboxone in that cup, it would read positive for buprenorphine. That's why it's of value to get the norbuprenorphine ratios.
So we actually have that case as well here, and I need to be guided on that as well. A person that was always 500 bup, 1500 norbup is suddenly 2000 bup, 14 norbup. So that seems like a clear case of spiking. And,
Yes.
and of course they deny the spiking. So I'm curious. I had a dissimilar case on that one where I presented a couple months ago, and I think that you were okay, sort of. I don't know how much you're okay with that particular case on not throwing out of the program over this, but with very, very close watch for a little bit. And that's what I was doing with this other one. I don't know if that's how you guys are. Are you guys moving it in any direction on that situation, or do you rarely see that?
Well, before we get to what we would do, let's find out from everyone else on the call what they would do with that. I'd be curious to hear what perspectives are. Anybody? There's no right answer or wrong, or there's no wrong answer, I should say that. Hopefully there are some right answers. Okay. What about Dr. Zhang? What do you think we would do on this one?
I think I would do exactly the same thing. I wouldn't change the treatment plan. I would do close monitoring for sure. I would call them back for more pill counts.
Yeah, that's what I would do. I would be much more vigilant as far as, hey, I would have an honest conversation with the patient. What I'm seeing right now is very concerning that you didn't take the medicine. And also at the time, I might have gotten another urine just to confirm and make sure it was an observed urine, at least the way we do it here, to find out. And at that time, if I would have done an observed urine, and this has happened before, then it's all of a sudden test pops positive for a lot of other substance. And then we realize that this person was worried that they were going to test positive, thus brought in their child's urine and put buprenorphine in it, substitution. And so then it creates an opportunity to have a conversation of, hey, I'm really worried about you and where your addiction is taking you right now. And we need to keep a closer eye on you. And that's why we're going to have you come more frequently. If indeed we get that positive test on the second one. Or if we didn't get another test, is we're just going to keep a little bit closer tabs and call you in more for random counts. And these are the reasons why. It's because it looks like you haven't been taking your medicine per the labs. And just, I'm always really upfront and honest about it, and try to give my rationale.
The other thing we had with him was he admitted to, for his words, accidentally eating a pot brownie. So we had one positive UDS with cannabis. So we ended up putting him on 3 days a week for 2 weeks.
Ah, okay.
Yeah, with all of that going on.
And, all right, I see.
Accidentally ate the whole brownie, didn't he? Yeah.
Yeah, it seems like he may have spiked it to hide a relapse and then came in with a pot brownie excuse.
It certainly raises some flags, and it's a cause to investigate a little further and to let them know that you're investigating a little further, because that gives them a sense that, okay, people are kind of keeping an eye on me. That's a good thing, and we're gonna just be careful.
Awesome. Do you guys have any other questions about this or anything else?
No, thank you for the feedback.
Thank you. For
Thank
the
you. That was great, because
presentation. Yeah.
very real life examples that we're all dealing with every day.
Perfect.
How about Dr. Tecker? Is there any sort of kidney affections or anything else like that that would affect the levels from time to time that we should all be aware about?
I would need to read up on the amount of dilution you could get with something like a stone blockage. I would think it would be subtle, because how much water could you really retain and then pour into a urine specimen? And
Right.
the idea of retaining a drug and not clearing it, but passing urine for days and days, that also seems unlikely to be a good excuse for strange results. But I could do more research. And
Just curious,
concrete.
just in general, how much should we really worry about whether somebody's got an infection or, you know, this sort of thing?
I think it's visibly, if they truly have an infection that's not being treated, you're going to see cloudiness. So someone should be able to note that in clinic. Honestly, you'd want them to go get that treated. So
Yep.
if they're taking antibiotics, like I said, I kind of think about the liver and activation, and maybe it changes the metabolic profile. So you might see a blip, but then it returns to normal after they finish the course of antibiotics. But I wouldn't expect it to just completely go crazy and you have a 2000 bup and a 15 norbup. I don't think it would do that. You basically have to not have a liver to have that happen.
Yep.
So I just, I think if your gut tells you that you've got metabolite coming out, you've got your creatinine available so you can see how diluted it really kind of is, and you've got some pH checks and temp checks, then it should inform you as to whether it seems like physiological urine. And if that creatinine is usually greater than 20 to 30, it's a lot less likely to have been diluted by the patient before turning it in. So.
Cool. Perfect. All right, guys. Lively Healthcare, are you guys ready for me to share your case? I hope so. I can't hear you.
Yes, you're ready.
Great. Whenever you're ready.
Okay, so we have a 26-year-old male who has only been with us since the beginning of September. I'm going to skip through a little bit of the information because it's a somewhat convoluted tale to tell. So he began using at about 12 years of age, started with marijuana inhalants. By the time he was in his early 20s, he had begun using prescription opiates, and then moved on to heroin, and then more recently, he's been using methamphetamine. Does not have a lot of social support. He doesn't have a significant family history of behavioral or substance use disorders, but he also doesn't have a lot of social support because he's burned a lot of his bridges, as with most of our patients. He's had 3 psychiatric placements as a child between the ages of 8 and 12, reportedly for oppositional defiance disorder. At 12, he went into the criminal justice system. And since then has been incarcerated as both a juvenile and adult for about 7 years total. He's currently on parole, and he has the following behavioral health diagnoses. He has substance use disorder, opiate use disorder, IV drug abuse, anxiety, depression, and social anxiety, as well as ADHD. So he came to us on the 11th of September as a transfer from another clinic in West Virginia that I will say is not affiliated with WVU at all. He presented with this polysubstance abuse dating back through those teen years. And he was with us doing pretty well until the 1st of October. Now, he did have a relapse on the 15th of September, but we dealt with that. It was on methamphetamine. The only change that we made at that time was him to a Remeron, prescription for Remeron. But on the 1st of October, that's when we started seeing some behaviors with him. He admitted at that time during group that he was using his Suboxone via IV, so he was injecting it. Reported that he was doing that because he was not doing well with the orange flavor of the Suboxone, and it was making him nauseated and causing vomiting. But at that point, he specifically said he wanted to get off the needle, and he wanted us to consider other medication options. And at that time, Dr. Borby moved him to Zubsolv. Within 2 days, he was calling saying that the Zubsolv wasn't working. He was having cravings. We talked to him about the route of administration and that could potentially be feeling like it was less effective because it wasn't going directly into the bloodstream anymore. But he continued to call on a pretty regular basis, asking to be put back on Suboxone, and we were saying to him, no, that is not going to be allowed until you come back in for your regular group time, that we weren't going to consider changing medication in the middle of a week. So on the, let me see what the date was. That was on the 1st, and then it was only a couple days later that he ended up relapsing on meth again, and he used meth for about 4 consecutive days, and he came back to clinic on the 7th of October, so just in a week period of time. Back for his regular clinic day, reported that he had used for 4 consecutive days, and requested to go back to the Suboxone. So at the same time, he admitted that he had also given one of his Zubsolv tablets to a friend of his to let them try it out to see if it was as ineffective as he had evaluated it to be. Of course, his friend said, yeah, it's pretty ineffective. So he's back to Suboxone now. And so Dr. Borby agreed to let him go back to Suboxone as long as he would come here to be administered the Suboxone so we could assure that he was not injecting it at that point. He came back for 3 days in a row and took the Suboxone in front of us, was able to show us that he could do it. So at that point, he was written a 3-day prescription for Suboxone. And then on the 3rd day, he should have been back in clinic again for a regular clinic day, and he was absent. So that brings us to this past weekend. And on Saturday, he ran out of Suboxone. So he called this morning, said, I'm out of Suboxone. Will you call in another prescription? And so we're at a point now where it certainly feels like behaviorally we're wheeling and dealing a lot. You know, he's saying if we call this prescription in this time, he'll come in on Wednesday for sure, and then he'll come back on Friday for sure. But it's just been a lot of behavioral concerns that we have, and we weren't sure how other people might view the case and what suggestions you might have for managing some of the behavioral components of the IV drug use, but then also, you know, all the back and forth and I need this and no, well, let's go back to Suboxone, well, let's go back to Zubsolv. It just has gone back and forth a lot in just a matter of a couple weeks.
And positive for methamphetamine, and he's also on Vyvanse for ADHD.
Awesome. Thank you guys so much for that case presentation. It was excellent. Again, I'm going to ask the participants, what are your first thoughts, insights, questions?
We're seeing this a lot at our clinic too, very similar type wheeling dealers on the 1 day at a time that can exhaust the clinic staff. And I don't have a good solution except to say that at some point you need to have multiple people present when you're very nicely say that you just can't do this anymore, is what we do, because you wouldn't want to do that alone.
It sounds like you've done everything you can to kind of, you're gonna have to set limits. I always say be firm but flexible. So be flexible within your policies, but you're gonna have to be firm with it. Because he sounds like he's testing the limits to see where he can find give, is what it seems like to me.
Sounds like at that point he might need a higher level of care. So you've already tried outpatient and encourage him to come in more frequent visits. So at that point, I will suggest to him, well, hey, you know, if you're having a hard time doing these requirements, what do you think about going inpatient somewhere? Because you're not only having a problem with the opioids, it's the meth. You're also on prescribed Vyvanse. There's a lot going on. You might need some sorting out, especially to break the whole habit of injecting.
And that actually was one of the things that that was another wheeling and dealing point. We offered that to him as an option. Of course, his response was he's been incarcerated essentially most of his late teen years and his early adulthood, and he had no interest in going back into a setting that he felt in any way limited his freedom. So he refused to do inpatient.
You said he was on parole, right? Or had a probation officer?
He is on parole. Yeah, he's on parole.
So, and he understands by having methamphetamine in his urine, he's already violating his parole. So he's setting himself up for future incarcerations, and maybe you can get him to decide, well, what kind of incarceration do you want? Like a 30-day or 90-day or something that will put you in there for years.
Okay. Yeah, and I mean, honestly, we have definitely tried motivational interviewing with him to get him to go into an inpatient treatment program because we thought the same thing relating to the injection. And he just absolutely refuses.
Seems like you guys are putting in a lot more effort than he is, and that can quickly lead to team burnout. Making sure I usually say like match the effort, but it sounds like he's just getting what he can.
Lately, he says he has no transportation here. His car's broke down, his mom's car's broke down, and he can't get here. He'd like to be here, but he just can't get here.
What does he think about Vivitrol? What are his thoughts on Vivitrol?
I don't know that we've ever discussed Vivitrol with him as an option. He would have to go through withdrawal from the Suboxone to do that, and that hasn't been something we've even thought about, I don't think.
I haven't even considered that. He's willing to go through withdrawals.
I suspect he wouldn't be very interested in Vivitrol right now, given the fact that he wasn't even interested in the Zubsolv. But I think it's a good idea. I would love, and this is a guy who seems like it'd be perfect to give Sublocade to, the injectable form of buprenorphine. given his challenges with injecting. One of the things that really strikes me about this case, guys, is how honest he was with you regarding injecting the medication. How did that happen? How did he get to a point where he was so honest with you about it?
He has an older cousin who is also in the program, and she's got about 500 days sober, and I think she has learned to trust us, and she has encouraged him to trust us, and so he threw it out there in the floor one day and let us just step back and go, wow, now what?
And he kind of pointed it out one day during group, like it was another thing in passing.
Yeah.
Yeah. Because that's pretty impressive. That tells that speaks a lot about how you guys are running your program, is that he was willing to do that, and then his cousin recommended him to come there.
Yeah.
So I think, deep down, he probably really does. I mean, everybody who's coming in, unless they're just coming in to get Suboxone to buy methamphetamine or to sell it to buy methamphetamine or something else, everybody's going to be coming in. At least a part of them wants to get better, and trying to really jump on that part that they want to get better and keep utilizing what you're doing to help him with that is wonderful.
I will say that he has done some good things, like Dr. Gorby had him pretty frustrated the day we were trying to convince him to go to inpatient. Yeah. And he got mad and walked out, and we were just sure he was going to, go on a bender and we'd never see him again. And I think it was probably about 25 minutes later, he called me from the parking lot and said, can I come back in and talk? So I think he wants it. It's just, I think he loses sight of wanting it every once in a while. I'm not sure.
Yeah, I mean, that's addiction, right? Addiction, it's ambivalence. And it comes and goes. It fluctuates.
The other family members that are in recovery, are they they live close to him? Are they a part of his support, or willing to be a part of his support circle?
Yes, when he stays clean and he's trying, they let him stay with them. But right now, they booted him out because he's
sure. Yeah, that's understandable.
Because I bet what Katie's trying to get at too, not to speak for Katie, but is if there is somebody in his life who can manage the medication for him so that he's not tempted to use it incorrectly when it's in his care. Mm-hmm. So if there's somebody in his life, if you can help him or one of the family members who say, hey, listen, we're trying to create a good program to keep him well. And one of the ways that we can do that is if you're willing to let him stay with you, and if you can manage the medication, you keep the medication in a safe place, in a lockbox or something, where you give it to him the same time every day, he doesn't have control of it, and watch how he does in the program that we've got, the structure that we've got, and see how that goes. So we can keep him on the same medicine, but you're going to watch him take the medicine every day. And that's going to make you feel better because you've got that, objective sign that he's actually taking the medicine in your presence and he's not misusing it. And then he's going to start feeling better knowing he's got that accountability and he can't sabotage himself when the addiction takes over and go right to the needle. Because as you know, and as he's elucidated, is people get addicted to the needle itself and what a challenge that is. And so that's a way to at least put in a contingency. It would be wonderful if somebody in his life is willing to do that for him.
His mom.
That's exactly what I was going to say.
How
did you know that? And then also, if they would be able or be willing to be of help bringing him to treatment, if he needs to be seen more frequently, which I think he does, if they would be willing to help, because you said before, he said, I'd like to be there, I just can't make it. Can they help him make it?
We'll definitely try to reach out to his mother and to his cousin.
Something that we've done a little bit with is our admins actually let us open up an Uber Health account, and that's helped us a ton with patient transportation. I don't know if that might be an option.
Wow.
Uber Health account.
Yeah, tell us more about that.
Lois might be able to speak to it. Lois sets it up, but we have when patient tells us where they're at, we basically send them an Uber, and they bring them here, and then about 20 minutes before they leave the appointment, we call on Uber. Is there anything else to it, Lois?
That's about it. It's
Yeah.
that simple.
Mhm. But it's specifically, she can do it on the computer. It's specifically for Uber Health. It's supposedly encrypted, HIPAA compliant, right?
Right.
Yeah.
Who funds that?
We have a grant money for it or
No, we
something?
just pay for it.
Or we're just paying for it.
That's our administration is very, very pro Matt, so we're very lucky there. But in general, the Uber Health, the cost to bring them here for the appointment is easily recuperated and then some just by being able to build the appointments. So it's
Yeah.
It's not breach anything.
And Logisticare should be a service that's available throughout the state that will pick people up and take them to their healthcare appointments too.
Yeah, Lois said the one limitation is anything over 50 miles they won't do.
For Uber, or you talking
Yeah.
about?
For health, yeah.
Usually not a driver.
Yeah.
available for that.
But logistic care, I don't think would be very useful in this patient that's on this case due to the 5-day wait period we have here in Charleston to get them.
I'm told, though, I could be wrong, but I'm told that the state has worked with Logisticare to remove that 5-day wait period. And so that's supposed to be the case now moving forward throughout the state of West Virginia.
I'll tell you, we're struggling, you know, and I don't know about your patients who are coming in from rural areas,
Yeah.
but with where we are, Logisticare is struggling to keep drivers employed. And
Yep.
so we have patients that are calling us right, you know, an hour before group saying my driver didn't come.
Yeah,
We have that a
we
lot.
have that too.
Okay.
Unfortunately.
Another thing that's interesting about this case is like people are shooting Suboxone tablets because of the insoluble components. I read some articles. They always have like a necrotic change, tissue change. So this person, I believe, if you do that a lot, and first thing is like it's amazing. Like you have naloxone and the buprenorphine together in your blood, you still feel high. Because I asked some patients, they don't, you know, they try it and they really feel high. So it's kind of naloxone doesn't work as expected. The second is like you keep doing this and like, you know, it's not, they're very likely you're gonna have, you know, necrosis somewhere on your body. So this person definitely needs physical care. Talking about, definitely. Talking about the clinic, combined clinic, you know, it's kind of very important.
With the tablets.
With the tablets, you should,
But not the film.
Not the film, yes. So the film could be very different.
A lot of patients who inject crushed pills, all of the binders and fillers will get hung up and cause inflammation. It becomes necrosis.
So another question is, this person is still on Vyvanse 30 milligram, because we do not recommend anybody in this stage of recovery like on stimulant. So this 30 milligram, think about what can this 30 milligram Vyvanse can do for this person. I don't know. I really don't know how much it can help him with his ADHD, or it's kind of helping with his, because he's still actively using methamphetamine. So I don't know whether he's really taking Vyvanse or just traded for methamphetamine. So that's
when he was diagnosed with ADHD.
Yeah, that was a whole area that you know could have gone into as well regarding this case. Are you all prescribing the Vyvanse?
Yeah.
Yeah, so you know that's not unusual. We see people being diagnosed with ADHD all the time, but they've been in active addiction. And it's really hard to make that a clear diagnosis with somebody, of course, who's in active addiction. The guy's still using methamphetamine. And so it really clouds the picture. People will have different opinions about this. But I agree with Dr. Zhang that I probably would not be prescribing Vyvanse to this guy at the same time. And yeah. But if you ask some of our other colleagues across the country, Dr. Bo, she might have a different, she's a psychiatrist as well. She might have a different take on this. But I would probably not be prescribing the Vyvanse in addition.
At this stage, I wouldn't, but down the road, if it's, because we do have patients who are kind of in our clinic, monthly clinic, who still definitely continues to have a lot of ADHD symptoms. Even we can observe those symptoms during the group. So we recommend those patients to be evaluated separately then you know, yeah, some of them get treated. Yeah, right. I mean, we're talking about a stable stage, like mostly like a monthly clinic patients.
Well, it depends. I mean,
it depends.
Again, you know, if somebody truly has ADHD, treating their ADHD is going to help their addiction. Okay, no doubt about it. I would probably try to go, again, I don't know if the guy has ADHD unless you had a really, really clear history of his childhood experiences and what happened during that time. When did he start his substance use, etc. And let's say it was really clear that he had ADHD, then I would probably try to start with a non-stimulant option for ADHD before I would move to the stimulants if necessary. Sometimes the stimulants are necessary just to get them better. Again, I think it's just too hard to tell in this guy, given how fresh he is in his active addiction right now.
Okay.
Just one other thought about the ADHD is sometimes patients' ADHD can be so severe that they can't participate in treatment. They're not learning anything from the therapy. And so it can't, especially in like a rehab setting, you really see that where the patients just can't participate in groups and make use of the treatment. And so it is a complicated situation where you're trying to reduce the likelihood of using substances by treating ADHD or enabling the patient to function well enough to gain benefit from the treatment.
Are you thinking we should like offer him Strattera or Wellbutrin? And
That's a good idea.
Yeah, that's what I would do.
which one do you recommend, one over the other?
If his liver is good, I mean, either is fine. So Terra to me takes longer to work, while Wellbutrin works a little bit faster. And he's not going to like it as much as he likes the Vyvanse. So usually I would only give a patient a stimulant, even if they have diagnosed ADD. If they are well along in their recovery, they're stabilized, and there is a reason to give it. For example, they needed to concentrate at work or concentrated with a lot of school work or even housework or doing something productive. Because just a diagnosis of ADHD doesn't really mean you have to give a stimulant.
And, you know, again, to be realistic, you know, you're going to have to ask yourselves, is that something that you're going to want to deal with now when you're trying to help him stay retained in the program with a whole Suboxone issue? And, or is that going to be something that you want to deal with a little bit further down the road after a couple of visits, once you get him stabilized with the Suboxone that you're prescribing? And what you're going to decide to do with that. You know what I mean? Is that because that's going to be a lot for him to have to take in right now too.
Yeah. Yeah.
You just want to be realistic about this.
Yeah, we don't.
It's also very possible his ADHD is not controlled by just 30 milligrams of Vyvanse, right? Because he's self-medicating as well on top of that. That's very that's also a possibility. I guess there's no right answer anyways.
Right.
So
so going back, Dr. Gorby, is that if he would have come into my intake, I probably on intake I would have told him that we're going to stop stop the Vyvanse, that we won't be prescribing the Vyvanse, that's going to be part of our program. And then let him know we're going to evaluate you as you move forward and see how you're doing with the recovery. And we're going to monitor your ADHD symptoms during that time. And I tell them, frankly, a lot of the patients I see who come to me with an ADHD diagnosis, it's because they started using substances at a very young age, and they've been intoxicated or recovering from the substances themselves when they're not intoxicated, and that affects your attention and your concentration. And so it doesn't make sense to me as the doctor to continue to throw medicines at somebody for those reasons until I've seen them over time and I can make a better decision about that. So looking back, I think at least you might want to look at future intakes as having that conversation when they come in regarding if you see them on stimulant medications like that.
Okay.
What about changing back to
From
film?
where,
Go ahead, I'm sorry.
I was just going to add that as a, sort of more of a, from a spoke standpoint, it can also be helpful to shorten that conversation so you don't have to listen to all of their reasons why you need to give them Vyvanse, because they're going to go on and on, is just to say that Echo doesn't support it, so I would do it for you, man. That's much quicker.
There you go.
Well, I'll just go ahead and take him off of it then immediately. Because we're going to tell him we talked to you all today, and that was the suggestion.
Okay.
What about the film? I mean, so is this person contraindicated for film, or should the person retry the film? The films?
I don't know, I raised the questions.
I don't know. I just feel like usually when a patient comes to DDU, they always want Subutex or tablets, but I always tell them like, no, you have to try film. So I know it's gonna make you nauseous. It's gonna make any chemical you start, it's gonna make you nauseous from the beginning. But again, you want to get off. You don't want needles anymore. You want help, and let's just try that.
What he's saying is we stand pretty firm regarding if somebody says that they're nauseous on a particular formulation, we usually don't change that. We say, yeah, that can happen for a lot of people, but that's something that really, most of our patients, the 6,000 patients we've treated over the last 20, they get used to it and they tolerate it and they do fine, but we're not going to change the formulation necessarily. Sometimes we will. I don't worry that much regarding the film or the tablet or the Zubsolv. So sometimes if I'm seeing blisters or some other problems in their mouth, then I might switch the formulation to one of those different things. But I rarely then would ever give the Subutex.
Right, but in this particular case, like a film could be more beneficial. Right?
So I agree with that. If there's still a risk that he might be injecting, then because of what Dr. Zhang mentioned earlier, I would probably stick with the film rather than tablet, just because of the risk. But I would also encourage you to look into the Sublocade to see if that could be an option, because there you don't have to worry about him taking the medicine at all. He just gets a shot for it.
We've already looked into it. Here's our office manager.
Yeah, we have a problem with the pharmacy. They said that they can't get it in stock because it's too expensive and the insurances won't cover it.
Yes. Does he have Medicaid?
Yeah.
Yeah, you'll have to get it approved through Medicaid. And if there's a good reason, and this is a good reason, then they should pay for it. But you'll have to get a prior auth through Medicaid. You'll have to speak to somebody at Medicaid and tell them your rationale.
Okay, I can do that.
Yeah.
From my understanding as well, currently it's only available through certain mail order pharmacies. So you'll probably need to contact Sublocade and find out what mail order pharmacies that they're using.
Okay, perfect. Thank you.
Do you guys have any other questions? We have 1 minute left. I don't want to cut you guys off, but.
I was just going to make the comment for Sublocade, since I work with Medicaid, that will require a letter of appeal to get that approved.
Thanks for the information.
Awesome, guys. Well, our session is over. We have our next one on the 28th. I'll send out those reminders. And if you guys have any questions or cases or anything, please just send them in whenever you feel like it. To everybody who presented today, I'll send you the notes back for your case so you don't have to rapidly jot all that stuff down. Thank you all.
Have a good night.
Bye.
Bye.